Hello and a very warm welcome to you. My name is Ray Lavery.
My name is Jessica Crooks.
And together we manage and run Trans Matters Worldwide and Trans London Meetup Group.
We do in-person events and online events once or twice a month. And right now we're hoping to move into webinars. We're bringing in experts and trying to educate.
That's it. And so originally this channel was actually my female to male transition line, but we have upgraded it from there. And as Jess has said, what we are going to do is we are going to do all things transgender. So there'll be fresh webinars, there'll be fresh interviews, there'll be some fun stuff if we can think about it and just record it, and things just to keep you occupied and have some fun and help you along your transgender journey. So to make sure that you don't miss out on anything, all you have to do is hit the subscribe button, and that way you will get all of the notifications of what we have coming up and you won't miss out on anything. So enjoy that and we will see you in there. So take care and goodbye. So again, hello. A very warm welcome to you. My name is Ray Lavery. I run Trans Matters Worldwide and the London Trans Meetup Group, and I do that with the lovely Jess Crooks, who is waving right now. So everything that's happening tonight, yes, it's our fault. We don't mind. Now, today we are delighted to be joined by a little bit of our panels. We've some extra stuff here that we didn't actually tell you in the copy for the event. But first and foremost, we have the wonderful, the only Mary Burke. And Mary Burke is, I can honestly tell you, is one of my favorite people on the planet. Not only does she know so much about what we're going to talk about today, she's just lovely. Like, she's one of the nicest people you'll ever meet. And so it's an absolute pleasure for myself and Jess to have her here. And we are forever grateful that she has agreed to do these webinars with us. Our aim in all of this here is simply to help you as much as we possibly can, to get the information that you can so that you can do the thing that feels right for you. Now, we are also joined, apart from Jess today, we are also joined by the wonderful Kat Egan. And the Kat is, with Jess, is one of two people, obviously, who is going to be sharing their experiences on hormones. So not only do we have everything about hormones, but you actually have a chance now to talk to people who are already on hormones. What is it like? What happened? Etc., etc. And you can get some real life experience here and get your questions answered. So for us, we're very excited about that. Kat, Mary, a very warm welcome to you. Thank you so much for being here. Thank you. That was, I think I just kind of ranted a bit. I tend to do that, don't I? Anyway, so I know that time is a little bit short here. So what I want to do is I just kind of want to get straight into, in fact, what I'll do is I'll give you a very brief introduction to who Mary is, for those of you who don't know. So Mary is director of the Gender Hormone Clinic, and she was also been working very closely with is it the London Transgender Clinic? That's the one. Thank you, Kat. Thank you very much. Here in London, Mary has over 20 years experience dealing with hormones, trans people. She knows everything there is to know about, all the stuff that we're talking about today. So it's absolutely amazing. Kat also works in the team and is actually, I think, the marketing managers, and that's that's it, for the London Transgender Clinic. And I don't know if you're moving over to the Gender Hormone Clinic. You are wonderful. Okay, brilliant stuff. So that's absolutely good. Now, Kat, can you just very quickly say, how long have you actually been on hormones?
I've been on estrogen for 3 years now, and I've been on progesterone for, I think, 4 months or so.
4 months. Okay. All right. That's great. Okay. And Jess, just again, so everybody knows, how long have you been on hormones?
I first got my hormones July 2020, so I guess probably about 2.5 years ago. Started on estrogen, progesterone about a year and a half ago, possibly.
Okay. Okay, wonderful. So there we go. We have a good amount of experience, if you like, in the room. I will say it's a little bit of a silly joke, but I've been on estrogen for about 30 years. I've been doing my damnedest to get rid of it. And it has started to work because I'm doing the complete opposite to everybody else. So yeah, wonderful. So there you go. So it sounds like you wanted to say something there, Mary.
Oh, right. Okay, I'm going to join the conversation. Thank you so much, Ray and Jess, for organizing this, and Kat for joining us. I want to correct you before we go ahead. I do not know everything there is to know, but anyone who thinks they do have a lot to learn. You know, I learn so much from my patients every single day, and there's no day that goes by that I don't learn something new. And that's why it's so exciting. And, you know, being able to help all of my patients is something I'm very passionate about and I love doing. So if you have any questions for me at all, now's the time to ask them, but I will hand on my heart, I don't know everything. No one does, but we are learning. And we've got EPATH, the European Professional Association for Transgender Health meeting in Killarney in April. So that should be very exciting as well, where we learn more.
Yes, brilliant. And I suppose the more the professionals share with each other, then the more everybody learns. The last thing we want is that people are just kind of guessing. And let's be honest, there's been a little bit of that going on in the healthcare systems pretty much across the world. Just a tad. Yeah, exactly. So look, what we're going to do is we're going to get some of the basic questions out of the way, guys, and then, you know, ask away, basically. So let's talk about this first. Let's talk about the very basics 101. So if you are a person who is questioning or is starting to, if you like, to do or thinking about doing the medical transition, in other words, going on to hormones, what sort of hormones is it that people can actually take, Mary?
Well, we usually start patients, once patients have a diagnosis of gender dysphoria, they'll usually make an appointment to come and see us. And we sit down with the patients. There's lots of different assessments we do. They have a blood profile done. And of course, we have a long conversation with them via video link and then in clinic. But we always start our trans female patients or our non-binary trans femme patients, let's not forget them as well. You know, we always start them on estrogen alone for the first 6 months, because approximately 35% of trans female patients will actually manage alone on estrogen or estradiol to block testosterone. So it's really nice if your body naturally does that, because it means then that you don't have to, you know, add any other medication like blockers. And there's an assortment, and we do offer an assortment. We tailor our prescribing to the individual patient, because some patients' GPs may not prescribe the more expensive blockers at 6 months if they need it. So if patients have to pay for their own medication, there are other options which make it financially viable for them.
Okay, all right. So basically, take it handy at the beginning.
Absolutely.
Okay, very good. And so
absolutely,
from, let's just say 6 months on, or again, I get a question here. What if you have a younger person who is maybe already on blockers? Does that change what you would prescribe at the beginning?
No, well, you see, we only see patients from the age of 18, which is a little unfortunate, but you know, that's the way it is at the moment. So generally when patients come to see us, they're ready to move on from just maybe blockers alone. We do get patients who've been through, you know, the adolescent service in the NHS, and they come to see us at the age of 18, some of them on their birthday to celebrate, and we'll start them on hormones. But yeah, we wouldn't stop the blocker, you know, we would continue with the estrogen and see how things change for them. And then, you know, assess them every 6 months for the first 2 years, and then annually. And then, you know, you can move to every 2 years after that once the levels are stable. You know, postmenopausal females don't have their bloods taken even before they start hormone therapy. So sometimes I think there's a lot of over monitoring, which can be costly. It's always very important to have a conversation with the patient, listen to the patient, look at the patient. Yeah, it's not all about blood levels, because as we know, they fluctuate, you know, every hour, every moment of the day. Our bodies are constantly, you know, changing. So the levels are going to change too. So it's not all about looking at levels. And then moving forward, You know, when patients get to about a year, 18 months, and their testosterone and estradiol levels are stable, okay, what we'd consider stable, you know, then we talk about adding progesterone. Now, we don't add it before this time because we know that progesterone can convert to testosterone, and it can kind of mix things up a little. It can make things a wee bit confusing. You know, you gradually, it's just like a natal female puberty. You know, you introduce the hormones gradually so the body gets used to them, and then you monitor how, you know, how one reacts to it. And everyone is different. You know, patients come in to me, Ray, and they'll say, oh, Mary, so when is this going to happen? When is that going to happen? And the jokey thing I do, because I love to have the crack, you know, being Irish, but I put my head under the desk and I say, hold on a minute. And then I come back up and I say, gee, I forgot my crystal ball, you know. So you cannot predict, and everyone is different. And I know that, you know, a lot of our younger patients, you know, they look at other people's transitions and compare them. I wouldn't do that. You're very individual. Every single, you know, person is different. So take your time and do it safely if you can.
Okay, I love that. So I have two questions on that, just from what you've said there. The first one, which I didn't know before, because I guess testosterone, too much testosterone is the same thing. Too much progesterone will change into testosterone.
No, progesterone can convert to testosterone. Okay.
But that's when your levels are very, very high of progesterone.
No,
right?
not necessarily. No, not at all. No, we will have, you know, patients who have a good estradiol level. You add progesterone in, and they're naturally blocking with estrogen alone. You add progesterone in, and you'll see the conversion because their testosterone level will just start to climb. But it doesn't happen for everyone. It really doesn't. And you cannot predict, but you can monitor. And that's when I say it's important to listen to your patients. If patients come back to us and they say, gee, Mary, you know, I've started, my skin has got really oily again. I'm getting spotty. I'm starting to grow some facial hair where I've had laser hair removal before. You think to yourself, okay, this sounds a bit like we've got some converting going on here. You check their levels and then you make an adjustment. Yeah. And it may be that patients want to stay on progesterone. And if you add a blocker, then it can stop that conversion, but they'll still get the benefits, you know? So it's an interesting scenario. And, you know, I find with my trans male patients, a lot of the time you can predict how things are going to go. You have some idea, because mainly 90% of the time you're just dealing with testosterone, over 90% of the time. With trans female patients, it can be a wee bit more complex. You know, I could give you 10 case studies and they're all different. I could give you 20, 30 case studies and they're all different. So that's when it's nice to have time to be able to sit down and have a conversation with your medical practitioner so that you understand. Also, some of my trans female patients, they don't want an injectable blocker. They don't want to block sexual function. You know, I can't say I blame them. So what we do is we give them an oral blocker, just a little, see how it works, so that they can get optimum feminization without losing sexual function, which they may never want to have genital surgery. Some of my patients don't, and that is their choice and their right. As a healthcare professional, my job is to educate my patients, to be there, to let them know what their choices are, and then to have a discussion about their choices and what it is they want to do, not to dictate what it is they have to do.
Okay, which is much healthier, because we are all looking for different results and so on. And also, I don't know, ladies, please jump in on this one here. At the early stages for me, I just wanted to go, you know what, let's just take this a little bit handy. You know, it's a marathon, not a sprint, was kind of the way I looked at it. I don't, Jessica and Kat, did you have that same approach, or were you just like, oh, give it all to me now?
I think there was definitely a certain amount of relief when I was finally able to get my prescription. I know there's a lot of people who certainly waited longer than I did, but that initially that's my main feeling around it. But I mean, for my money, it's just been the regular checkups have always been really good. You know, sort of checking every 6 months, taking blood tests, and just going with the flow. Really, didn't want to overface myself too quickly. Okay,
and what about you, Kat?
So mine was a bit of a mix, because I started my estrogen on the NHS system, and with that there was a lot less transparency with the types of medication you can have, like how it would interact and stuff like that. So very much I think I'd been on the wait list at that point for maybe 4 years. Yeah, I think maybe 4 years. Wow. At that point I was very much like, just give me anything. Just, I don't really understand what I can be given. Just give me whatever you're recommending as sort of hormone therapy as a generic thing. Which has been more interesting because then I introduced progesterone into my system like this just before Christmas and stuff like that. And that's been a really interesting process of like actually being able to having some transparency with my hormone care.
Okay. All right. So again, two very different viewpoints in here. By the way, I will just say that I see the questions mounting up. We are not ignoring you. We'll get to them. We'll just get these basic ones done first. So don't worry. Okay, so that's pretty good. Now, another very simple, well, maybe it's not simple, is that very often when you're looking up at stuff online, they'll give you scales of, well, you should be between this level and that level, and your blood should be within this level and that level. And mostly for trans men, that's kind of the way that it is, as you were saying there. But just how individual is this for each individual? Like, I mean, are there any benchmarks that a trans woman can look at and go, okay, this is how it will work for me, or I have a rough estimation? I know the crystal ball thing, we got that, but just like how far out of whack are these scales that you see on all of these, you know, articles online about this?
Yeah, well, you know, in the UK, we kind of say you're looking for an estradiol level, say between 400 and 800, and you're looking for a testosterone level less than 3, you know, to achieve optimum results. But I often see patients with slightly higher estradiol levels and they're comfortable on them, you know, and, you know, in a female cycle, in the monthly cycle, levels will range from 150 to 1700. So if you have a fluctuation with estrogen in a trans female patient, then, you know, it's quite natural for that to happen. So, you know, you can have guidelines. You know, I've had patients come to me and, you know, their estradiol levels have been over 6,000 and they've been on far too much medication. And likewise, I've had patients come to me and they've been on very low levels. So it's a difficult one. And again, I say this, Ray, and it, you know, it's about having a conversation with the patient. How are you feeling? Are you experiencing any side effects? You know, or is everything okay for you? And yes, obviously, you know, look at your blood levels. But if the patient is doing well and there's no side effects, you know, they're just something to take into account. You know, obviously we have to practice safely, but I always have this conversation with patients. They might come in, the levels might be low, but actually they're developing beautifully. They're feeling well, both physically and psychologically. So I never make, you know, a judgment on just one blood test alone either, or one blood level alone, because that's only one moment in time. And it's not the sensible thing to do. You know, if you have a concern, yes, repeat the blood test, have a conversation again with the patient. But again, it's not all about levels. And interestingly, Bagus, I think it was conference, was it last year, or the year before, which is, sorry, the British Association of Gender Identity Specialists. It was Dr. Carl Neff from the Dublin Gender Clinic. And I was very interested to hear Carl say that they don't do at all as many blood tests as we do. They have a conversation with the patient and find out how they're doing and see how they're transitioning and their physical changes. You know, so I think a combination of the two is absolutely perfect. As I said before, you know, for years I worked with postmenopausal females. You don't do all of that blood testing. You listen, you see how the patient is doing. Are they well? Are they having any side effects? You know, so it's important to take a lot of things into account.
Right. So Kate.
Sorry, just to add to that as well, like, I think it's also worth noting that not like, and please correct me if I'm wrong on this, Mary, but like levels don't always correspond to how rapidly you'll see changes. They don't correspond to how much change you will see. It like if you're sort of trying to bulk up on as much estrogen as possible, you could end up with minimal changes. You can end up with adverse effects, all of this type stuff that means that it's not as simple as one number higher equals this amount of changes. It's a lot more.
Yeah, you're absolutely right, Kat, because I've seen patients, you know, even losing their hair, taking too much estrogen, you know, ending up with hair loss because of it. So, you know, it is about kind of getting the levels right where you're physically changing, and change takes, you know, 3 to 5 years. You know, it doesn't happen overnight, and it is about being patient. You know, you can see young girls going through puberty, and some of them change really quickly, and others, you know, they can be 16 or 17 before they, you know, even start to physically change or to menstruate. You know, everyone does it in their own time. Yeah. So I would advise, you know, patients, I know it's difficult because we all compare ourselves to others, but, you know, take your time and do it safely, and try not to compare yourself to everyone else. Because you're right, Kat, you know, it's not all about achieving levels. Your body will change, you know, in its own good time, and it's about being patient. And actually, the older you are, the slower the change may be. And as we age, you know, our faces become more androgynous. So the slightly older patient, you know, things will take longer to change, just like healing will do, you know, following any kind of a surgery or anything else.
Okay, but that's all actually very interesting stuff. Actually, there was a lot of stuff about sort of older and younger, you know, people, whether it does make any difference. That for me, I will say it again at the next one. I went exactly the same speed as everybody else, but I would just like to ask the ladies now, because, you know, say for instance, the first 6 months, because you were both clearly on different sort of doses and stuff like that. So maybe Jess, if we go for you first, for the first 6 months, what sort of changes did you notice?
First 6 months, I would say the biggest change for me felt mental, I suppose. I've heard a couple of people describe this. There's a great author, Samantha Allen, who said, if testosterone looked the way it felt in my body, it would be lime green and corrosive. It's a wonderful quote. Yeah, I felt very clear all of a sudden. That was the biggest change in my first 6 months. A lot less foggy and a lot more present than I had done previously.
Would that have been because you just felt calmer because you were on hormones now and you weren't sort of freaking out going, I wish I was on hormones? Like,
I mean, I haven't felt that way since.
right.
You know, but that's an interesting point too. It's difficult to sort of accrue specific changes to, you know, everything we're doing. Transition's such a big thing. Whether it's mental or physical is different. But that was my biggest experience, I would say, first 6 months.
Okay. Oh, after day one, I felt calmer personally, but that was just me because I was freaking out the day before. What the hell am I doing? You know, so you know, it felt much calmer. So, what about you, Kat? What did you experience the first 6 months?
I think same like that. It was the mental change quite a lot. And this feeling a bit more calmer, feeling a bit more of a spectrum of emotion rather than this very like blunted effect, I think, that testosterone feels, at least in my experience. And like, yeah, I think it was an element of just feeling more complexity within my emotions in a way that I didn't felt like I like was feeling on testosterone beforehand.
Okay, well, so both of you, neither of you have described anything physical.
No, I mean, I had some breast growth. I had no real fat redistribution around my body by 6 months or so. Yeah, I think the most noticed change was a bit of breast growth, and yeah.
Okay, and can I just ask, this is a personal question, so tell me to shut up if you don't want to say. But my understanding is that a lot of trans women, and in fact anybody you know, going through puberty, any female going through puberty, that the nipples actually hurt.
Yeah.
You had that?
That's not an industry secret, I don't think, right?
Right, but she didn't have to admit that she went through it. Is my point.
Sure. Yeah. I mean, yeah. So certainly the first 6 months, but I think more than anything else, the mental side of it was the biggest change for me over the first 6 months. You know, 6 months to a year and a half, I would say, was more so for physical changes.
Okay, so when did you're saying sort of a year and a half is when you started seeing the physical changes? Is that about right? Yeah, so that's quite a time. What about you, Kat?
I think that there was other than breast growth with regards to physical changes, I think it took me a while to tune into them, I think, because I think they were happening, they're clearly happening, but it wasn't until like a year or so ago, so probably about 2 years on, that I started to like actually notice quite a lot of difference in my body with when it comes to fat redistribution. And then I also had I think it was about 2 years ago, I realized that I'd shrunk, which was something that I didn't think was going to happen. I used to
You shrunk?
yeah, I used to be 6 foot, and now I am 5'10", which and my shoe
2
size
inches.
is also now size like 7 from a size 9, which didn't expect that to
How
happen.
bizarre.
But yeah.
My feet grew, but I didn't get height. I'd have done anything to get some height. I'm really sure. But yeah, so okay, that's amazing. I've never heard anybody say that they shrank before.
Yeah, so sort of talked to a few people about it and looked into it and stuff. It seems to be to do with like the joints in the spine and stuff compressing, which is sort of the medical side of it. But I'm not a medical person, so it's not fully my area to comment on. But it's yeah, I've met a few people who have also had it happen. But yeah, it's strange. It's so it only really caught up with me when I went to go, and I think I was doing a checkup at my GP, did the height measuring thing, and I was 5'10" instead of 6 foot now out of nowhere, which was strange.
Wow, I didn't know about that. Okay, fantastic. Thank you, ladies, for sharing. Now, Mary, you had talked about this a little bit earlier on about the sexual function side of things. Now, can you tell me here, because my understanding, maybe it was bad, is that once you're on estrogen, that the sexual function decreases, and also genitals shrink. Now, not like physical height, but the genitals actually shrink. And a lot of people have said that, a lot of ladies have said that, particularly the scrotum completely shrinks. But maybe that's not in the first year or whatever, but it does happen. So what is your when I say experience from listening to other clients? Clearly you don't have experience in this, but you know,
No.
what would that be?
It's an interesting one. Any muscle, if you're not exercising it, it will shrink. Okay. So, you know, the penis it's a very muscular, vascular organ. Okay. So if you're not having erections and that blood flow isn't rushing into that muscle, it will shrink if it's not active over time. But it's actually the muscle that's shrinking. I remember years ago having my leg in plaster cast, and when I took it out, you know, one of my legs was a lot bigger than the other. The one that were in plaster cast, because the muscles weren't active, had shrunk. And it's the same thing. So, and the reason the scrotum shrinks is because you're suppressing testosterone. So the testicles will shrink, okay, because you haven't got all of that, you know, sperm production and ejaculant and that in there, you know. So it's quite common that happens. But what patients also think happens is that the skin shrinks, and it's a difficult one to understand. What I always say to them is, don't worry too much about that, but you can actually stretch the skin in that area, because what some patients worry about is when they go to have genital surgery, if everything has shrunk, then they won't get so much depth when they have a penile inversion or the other procedures that you can have done. So I would say not to worry too much about it. But I have seen with some patients, what happens is if they're not having regular erections and then they do have an erection and you know, the skin has tightened a little because it's not being stretched, they can get a phimosis, so they can get a tightening of the skin and it can be very uncomfortable. So some patients, what they'll do is apply a little bit of testosterone. There's a testosterone cream that one can get, which can help. But I also say to the patients, you know, just to, like you would if you're going to give birth. I was a midwife for many years. You know, you apply oils and stretch the skin to keep that elasticity there. It's absolutely okay to do that. But I do also understand that some patients, you know, have a dysphoria about their genitals. And the last thing they want to do is, you know, to be stretching up something that they really don't want to be there.
Right. Well, I think that's kind of reasonable. It's kind of a double-edged sword on that one. But, you know, again, there's a lot of stuff that people don't really talk about. You know, and I have to say there's tons and tons of timelines out there. And
Yeah,
lots of people go, yay, this is how it worked for me, and it's all brilliant. And like I'm ahead of the curve at 6 months, and you know, I got a size D. You know, there's a lot of this kind of stuff going on, which I find very unhelpful, because that's where people I guess are comparing themselves. Well, I'm not there yet, so they get very upset about it. So
yeah,
I like your advice of, you know, chill out, but I also like to, you know, get out there the stuff that's not in the timelines, the stuff that people are not telling you about, because you kind of need to know
yeah.
what you're
And
kind of facing.
And again, you're right. You know, the girls are so right in what they said, Jess and Kat, when they said, you know, when we see patients 6 months after they start, you know, it is the psychological benefits, this calming effect, being able to feel, to not feel that inertia, you know, to actually feel something, to be able to cry, you know, because testosterone stops the tears. You know, there's a physicality about it. It does stop the tears. So I think they're absolutely right. Initially, it is that calm and the huge psychological benefits. I remember speaking to a psychiatrist about this. 70% of trans females, their mental health improves when they go on estrogen. It's quite incredible. But also, you know, again, talking about, you know, the sexual physical activity. You know, some people think that, you know, okay, if you're trans female, you have to suppress testosterone. You have to know what it's like not to have sex drive, you know, like, well, of course, natal females have sex drive, for Christ's sake. We produce testosterone, progesterone, and estrogen, and so do assigned males at birth. So, and I also think that, again, it's a conversation you have with a patient. Do they want to maintain erectile function? You know, have they a female partner? Is that part of the relationship that they want to continue? You know, I'm happy to have a conversation with anyone and to try and help them achieve what they want to achieve in a totally non-judgmental way. You know, I don't think you have to necessarily. I think it's good to have a sense of feeling of knowing what your testosterone level, you know, will be like beforehand, but before, you know, going on to genital surgery. But I think, you know, if you're waiting, you can be waiting a long time to have surgery. So do you need to, you know, block all of your testosterone for 6-7 years? I think it's a discussion to have with the patient. I don't think it's one that we should dictate at all.
Okay, fair enough. And I know, because we kind of have talked a little bit about blockers there, but let's bring that sort of build that conversation into I guess the side effects. So once somebody goes on estrogen, let's talk about estrogen first, and then like, what are the side effects? When I say side effects, so some of the things that could happen that are not good, and then some of the things that in time somebody should expect. And I'll ask the ladies to jump in on that as well. But just for you, what would you say to that now? What would be the side effects?
You know, with any medication, there's always a possibility of side effects. And this is something that we talked to the patients about beforehand. And, you know, obviously, if you have an estrogen dependent cancer, which you can have as an assigned male at birth, you wouldn't be prescribing estrogen. You take into account, you know, the family history. Is very important. We will often, you know, if patients have complex histories, you know, they have a history of maybe a deep vein thrombosis, pulmonary embolism. We've had those patients. So, you know, you need to be having a discussion with either a hematologist, maybe possibly an endocrinologist. We will refer to specialists outside of the practice with patients with complexities. But I have to say that, you know, sometimes it takes time, because, you know, it's very important to work as a multidisciplinary team in the best interests of the patients. But there's never been a time where we have not been able to start to start estrogen for a patient or any form of medication. But it is about doing it safely, and it is spending that time initially with the patient, making sure that, you know, not only are they medically safe, but they're actually physically safe to be transitioning, you know, where they're living, you know. There's lots of different aspects to take into account.
Okay, but overall, I mean, we are talking about drugs that are very readily prescribed all across the world. I mean, in the US, estrogen is the second most prescribed drug in the US. So that's a huge number. And clearly there's a lot of women on HRT for that one, you know. But to me, a hormone is a hormone. We all have hormones. I mean, I always hear this one. It's like, oh, you can't, you know, you have to come off to do your, you know, surgeries and stuff like that, you know. But, you know, a normal woman facing surgeries doesn't have to come off her estrogen to have an
No,
operation. So is there a big
if you're
difference there? Is that real?
Yeah, it is real. And there's different types. You know, there's in the UK, in America, lots of injectable estrogen is used. In the UK, no, we use either oral estrogen or transdermal patches or gels. So there was an article written in 2019, published in the British Medical Journal, and it was about this very conversation. And actually, the conclusion was, and I was asked by the General Medical Council to send them a copy of this because someone was querying our practice at the London Transgender Clinic. And actually, there's no evidence that patients on transdermal estrogen are at any increased risk of any thrombotic episode at the time of or around the time of surgery. So any of our patients on oral estrogen, we will transfer them onto transdermal. I mean, it's difficult enough going through a surgery, but to put someone into a postmenopausal situation and withdraw all their hormones, you know, I know the facial team in Marbella, they don't do it. I know lots of other practitioners, and I've read lots of papers on it, don't do it. And, you know, I wouldn't like, it's like a natal female, you know, you don't stop ovarian function when she's having surgery. So why would you stop hormone therapy?
I'm with you on that one. I mean, I ignored that advice completely and did not listen to the surgeon. And guess what? It was fine. Nothing happened. So, you know, I get that. So, ladies, I guess back to you. I mean, not any sort of side effects, but, you know, are you, so you're in the UK, so that means that you're on either patches or creams, is that right? The oral. So when you say the oral, is that like a tablet?
Yes.
Okay. And so how does that work then? How often do you take it? Like, obviously depends on your dosage levels, but sort of like I've heard the patches are sort of like on the arm sort of once a day usually. But what about the oral?
So for oral ones, because all my estrogens are oral based. So I have in the evening I'll take my sort of my milligram dosage of estradiol, and then I'll also take alongside it, I'll normally take my progesterone, because progesterone has certain you need to not have eaten a certain amount of time, and also it has certain it can make you a little bit sleepy within like the first few hours of taking it and stuff like that. So it's just easier to take it in the evening, and so that's what I do for that, really.
Okay. And Jess, what about you?
So I started on the tablets, and then after I think a year or so, we moved back to the Sandrina gel. So I open a little sachet in the morning. I spread that on my inner thigh, and I do the same before I go to sleep at night. And I take my progesterone the same way Kat does.
Okay. And have either of you changed from one to the other, like sort of changed from the patches and then got onto the sort of the oral one?
Well, there was a shortage in gel. I think it's still sort of going on in certain places in the country, but so middle of summer last year there was just nothing available, or very little available in London that I could get hold of. So I went back on the tablets for sort of 4 months or so.
And did you see any changes in yourself going from one brand to the other?
I think it's more specific to me. I think like I'll take if I'm taking the pills, the estrogen pills, I'll take them alongside like vitamins and stuff, and it's better to have a full stomach for that. I tend to not eat in the morning, so I'll always forget. Like it sort of just ruins the routine a little bit. Whereas, you know, for the gel, I can just put that on when I get up in the morning and I'll never think of it again, kind of thing. So it was routine more than anything for me.
Okay, fair enough. Okay, but no difference in sort of effects or anything like that?
No, not strictly.
Okay, right. Okay, I'm going to throw in one of the questions that we got here, and this one is definitely for you, Mary. So, can you advise on injectable estrogen? So, my partner's prescribed it, and she is from the USA. No, you just said you don't do that, but do you know much
in the
about this?
UK, you see, GPs is not something that's that GPs can prescribe on NHS prescriptions, and a lot of our patients, the GPs will prescribe because we'll share care with them, and it works very well. So no, you can't get it in the UK at the moment. Just to say, the patches are applied either twice weekly or once a week, depending on which patch you use. It'd be a nightmare if you're putting them on daily and taking them off. But you definitely, I know patients will import injectable estrogen online and use it, but it's not readily available at all in the UK.
Okay, but have you had any experience with people taking that? And I guess what's the difference, or any advice for anybody who's doing that?
Yeah, I mean, I have patients who come from the US and they're in the UK for a short period of time, and they'll bring their estrogen with them, and they might come in and say, look, can you just check my bloods, and that. And their levels end up being pretty similar, because it's not something that I prescribe here in the UK, because it's not readily available. I mean, as far as dosages, I'd have to look at their medical recommendations for it. But, patients do very well on it. Like, different countries do different, do things slightly differently. Like in the US, spironolactone is used a lot. And spironolactone's been around for such a long time. Initially, I think, as an antihypertensive, and then they realized that side effect was that it affected erectile function. But it's also a diuretic. So it means that you can pee more while you have it on, but it's it costs pennies. So it's readily prescribed, to block testosterone in the US, and it's very cheap. But you have to kind of assess the patient that it's suitable for. But and the WPATH guidelines, will still recommend it. So it varies between, countries as to what patients will be on, and indeed it varies between dosages. I was fascinated to see some of the prescribing that was done throughout Europe the last time I was at EPATH. So it'll be very interesting to see how things have changed this year at the conference again.
Okay. All right. Well, good. Okay. So, well, thank you. And so look, the person who asked that, if you have something more specific, because like any advice is very broad. So if there was something specific that you wanted to ask, then yes, we'll get that answered for you as well. So what I'm going to do, I'm going to pop over to some of the questions I think that are being asked, because they're really starting to mount up. So Jess, can you look at the ones in the webinar chat, and I'll look at the ones in the actually, do you know what one? I'll do the one that we got on the meetup. How about that? So the very first question we got, because in fairness, it came in first, was apart from hormone therapy for older trans people, certainly for MTF doses, they seem really quite high. So I realize many of the risks that cis women face with HRT do not apply to the trans community, but there are other risks. Why do we not reduce our doses down to a similar ones for those who are postmenopausal cis women? Is that safer? And then another question, what is the peer-reviewed evidence for dosing regimes in elder trans populations? That was a lot of stuff in there.
Yeah, a lot of stuff in there. Very interesting. I had one of our staff members actually asked me the other day, could I look at what their mother was taking as a postmenopausal female, because she wasn't feeling well. And she actually, her GP was microdosing. So I'm not surprised that she wasn't feeling well. She was on a 50 microgram Everol patch. And then, I'm also a member actually I haven't kept up my membership, the British Menopause Society. But the last meeting I went to with them, the most senior, some of the most senior doctors and practitioners there were on, 3 milligrams of Sandrina gel, which would be the maximum dose that I would prescribe generally for my trans female patients. And again, I say this, our bodies will react to any medication differently. So, you cannot, there isn't a rigid book that's going to be written and rigid guidance. It's about monitoring levels and monitoring the patient. Okay. Everyone is different. Again, it's so much easier with trans male patients in many ways, but with trans female patients, you have to monitor the individual and check. And once they get on a steady, stable dose, yes, things change over time. I see sometimes patients, post-genital surgery. I always say to them, come back to me 6 months, 3 or 6 months after your surgery. We'll check your levels and make sure that everything is okay. And then I write to the GPs and I say, look, this female now should be treated absolutely like any postmenopausal female. And once their levels are steady and stable, do you have to do long-term monitoring of that? No, you don't. Do you have to reduce levels? Not necessarily. It very much depends on the patient. It's not something that you can predict, and one size doesn't fit all.
Yeah, I think that's kind of the bigger message here, is the one size doesn't fit all.
No,
I think that does answer a question we've got here also, from Alex. He says, well, they say, I'm 47 years old and I started estradiol 3 months ago and had a GnRH blocker. Would hormone treatment going forward be different for a younger person? And does an older body respond okay to these hormones? So I suppose what you're saying is everybody's different.
Absolutely. And I always say to patients, I cannot predict how you're going to respond to this. But, if you don't try, you'll never know. And if you feel better on it, and, the GnRH analogs, the injectable blockers, I'm always surprised, because that will bring an assigned male at birth's testosterone level down from, it could be in the 20s, it could be in the early 30s, down to below 1. I'm always surprised that patients, don't react more. In a sense, because testosterone, is a driver. It kind of gives you focus and many other things, and also for trans female patients is something that they don't like. But actually, very seldom do they have negative. I have a few patients who have, they might have, interestingly, skin reactions to it. Some patients, they almost get a lethargy, which one would expect, but very few. Very, very few. I would say maybe even less than 5% of patients would have negative effects from the injectable blockers. And the other oral anti-estrogens that we use, blockers, anti-testosterone that we use, anti-estrogen.
No, we want the estrogen.
You want the estrogen, just you have to remind me about that one, Jess. But the other blockers we use them in such minute, doses, that and they can work incredibly well. So I'm always surprised that we don't see more side effects in many ways. But if you monitor and safely prescribe, don't overdo it, keep within safe measures and guidance, then you should be fine. If patients have problems, you always get back to us. Yes, get back to us.
Less is more. Yeah, because you can always up the dose if it's not going quite the way that you want, but if there are already negative side effects, might take you a while, to get back from that, if indeed you can, Now, another question has come in here on the chat. I don't know if you want to do some from Carly. Well, no, just there you go. Okay, is there any evidence that HRT can negatively interact with behavioral medication, such as atomatextrine, I think that is, or Strattera?
Strattera. To be quite honest, I'd have to look them up. But, again, you can have, we don't tend to see negative interactions with trans female medication, particularly with estrogen, okay? We tend to see it more if you have a psychotic patient and you put them on testosterone. That's when you can see an effect. That's when you have to be very careful. But of course, we're talking about FTM today. So, but I always look up, if it's a medication that I'm not familiar with, I'll always look up interactions, so that we're safely prescribing. And if it's, if we have patients who've been on long-term medication, have chronic comorbidities, they're usually under specialist supervision. So I will always write to the consultant and say, look, this is our plan for prescribing. We would very much like your specialist opinion or input, so that we can monitor this patient safely. So we've never had a patient that we haven't been able to prescribe for. So I think that answers that question. I think you can safely prescribe, and I don't call it hormone replacement therapy. It's gender affirming hormone therapy. HRT is for postmenopausal females. TRT is for testosterone replacement therapy. But, what we prescribe is gender affirming hormone therapy, and it is affirming.
It certainly is. It certainly is. I think everybody sitting here can attest to that one, Okay, there's another question here. I'm going to take another one from the chat here. It's somebody saying, I've heard that for monitoring via blood test, the results are more meaningful if taken immediately before the patient's next dose. Is that true? There's a lot of myths about this one.
Yeah, there are lots of myths about it. And yeah, okay, if you're monitoring like peak and trough levels, if you have a patient on testosterone, okay, or you want to check their low level if they're on libido, well, then you'll do it. It is interesting to say to patients, if you can have your bloods done before you have before you have your medication, then what a kind of trough level is. But generally, when you take medication, what happens, be it transdermal, be it a patch, be it a tablet, it takes different times for your body to actually absorb, and different medications will have different half-lives, so prolonged actions and things like that. So we always say to patients, this is the other interesting, I always say to patients, if you have your bloods done about 6 hours, kind of set a rule, have your bloods done about 6 hours after you take your oral medication, if you can, around that time, 4 to 6 hours, or after you apply your gel, 36 hours after you apply your patch, if you're on a twice weekly patch, because then you're kind of like mid-cycle. So it gives us some idea. But we always get patients that'll say, oh, I didn't put on my gel this morning or whatever. And that's fine. As long as we know what happened on the day, then we kind of know what we're dealing with. But again, at the same time, you're also saying to the patient, because sometimes, I'm training nurses at the moment, and they'll say to me, well, Mary, the levels are this and the levels are that. And I'll say, and how is the patient? And they'll say, God, they're doing great and they're happy and content and the physical changes are great. I said, well, there you go. There's your answer. You needn't worry too much about the blood levels, once they're within, kind of safe range. Yeah.
Okay.
To follow up on that, we've got a question in the chat. Is it essential to take HRT at the same time every day? I know you were mentioning about sort of missing stuff there.
Yes.
Is it important to be regimented?
No.
In that sense?
No. And a lot of my patients, Jess, would struggle with being regimented. And a lot of them, would struggle to remember to put their medication on every day. I always say to them, I sometimes, if I'm knee deep in admin, I might have booked a phone call with a patient. I have to set my alarm first thing in the morning and look at my diary because I'll forget it. If you said to me, as I'm postmenopausal female, Mary, you have to take your tablets, twice a day at this time, I'd be like, look, the only thing I do twice a day is brush my teeth. I'm not going to remember. So for me, I have a once weekly patch and I can just about, manage that. So I totally understand that what you do also as a prescriber is you say to the patient, look, what's going to suit you and what's going to suit your lifestyle? And then you work from there. Yeah.
Right. So don't freak out is the bottom line. Don't freak out.
No, just take it whenever you remember it, but don't freak out.
Right. Sorry.
Just a little thing from me is I before I took them in the evening and stuff, I used to take my estrogen in the morning. I genuinely had to keep a strip of estrogen pills in my handbag at all times because I would always forget everything. And so I'd be on the train platform on the way to work taking estrogen pills because I just remembered in that moment. So yeah, and
I love it. The same person has another question, and it actually might tie in with what Kat was actually saying earlier, because we've talked mostly about estrogen, not so much on progesterone. So I just want to ask one question before I get onto that one, which is, when's estrogen, right, we've got that, but then you start somebody on progesterone, what is the actual difference that a person would expect? What does it do? Because I know, women going on cis women going on HRT have to really fight to get that because they're like, that's got nothing, that's to do with the reproductive system, we don't need to worry about that. But all the trans women that I've talked to on progesterone have got, whoa, it makes a big difference. So ladies, how would you comment on that?
So I'll jump in. So so I think very much with me starting progesterone a few months back and stuff, it was a sense of slightly more calm. Like I wasn't I was feeling a wider spectrum of emotions, but I was feeling them a lot stronger in a way that was sometimes a little bit out of my control. And progesterone's given me a little bit more of that control and a little bit more levelness to me, I think, with regards to the mood stuff. With regards to bodily development, I mean, I've ended up sort of having sort of seeing more breast development with progesterone after I'd sort of stopped having as many growth spurts and stuff with it, which was interesting. But I mean, it's also difficult to say whether it actually properly stopped having growth spurts, but it seems to have had an effect on that. But with progesterone, it's been a lot of a mood thing with it as well, and also sort of an increase in sex drive and stuff like that that's also come with it. That's been good.
Fair enough. Sorry, go ahead, Jess. Yeah.
No, arguably, I think that's the biggest one for me. I think libido has certainly increased in a post-progesterone world.
Yeah,
Nothing
because
wrong with that.
No,
as
not at all.
as we were saying, and girls, you're absolutely right. As I was saying earlier, progesterone can convert to testosterone, so it can have that positive effect. There was a paper written by the Canadians, and it was published in the American Journal of Metabolism and Endocrinology in November 2019. It was a very interesting paper, and I like the Canadians. They're very practical in the way they deal with things and that. And what they did was they looked at the effects of progesterone on natal females, the multiple positive effects. You see, progesterone, some doctors and some endocrinologists forget that actually, and even some gynecologists and obstetricians forget that progesterone isn't just about its function in the uterus and the female organs as such. You know, it has a positive effect, just as Jess and Kat were saying, on your moods, on your sex drive. It develops the glandular tissue, the rounding out tissue of the breast. It has a positive effect on your lipid profile. It's meant to have actually some effect, and I heard this also, I mean, it was written in this paper by the Canadians as well, but I also heard this at a conference, the British Menopause Society, that it's meant to have some effect on the osteoblasts, which are the bone builders. It also has a positive effect on your brain and heart tissue long term. So there's lots of other, it suppresses the central nervous system. So it has an natural anti-anxiolytic and antidepressant effect. And that's why you take it last thing at night in an empty stomach, or indeed, you know, you can, you know, some patients will pop it rectally at night, but and that's because it suppresses the central nervous system, so it calms things down. And I've had a few patients come to see me, and you know, they've been quite agitated and slightly, what I describe as slightly wired and all over the place. And you know, you give them progesterone, and some of those patients, I'd give them 200 milligrams of progesterone, and they turn around and they say, do you know what, Mary, it has just changed my life. I sleep and I'm calm, and you know, I would say with any patient, it's worth trying. Natal females, there's a small percentage of natal females that don't respond. And we're talking about body identical progesterone here. And this is, you know, some people get it mixed up, because under the heading progestogens, you have the synthetic progestin, and then you have the body identical progesterone. So we only prescribe progesterone under the trade name of Utrogestin. That's all we prescribe, because you know, the multiple beneficial effects, and we see it all the time. I would just like to do a study on it, because I think it's so important. And I see a lot of patients now. I've had a few patients recently from the States, and you know, they were all on progesterone now. And also I know there's a lot of practitioners in the UK, besides myself now, prescribing it, and even some of the NHS GICs. So it's wonderful to see that transition as well, that change as well, you know, in prescribing. And it's just in listening to patients and observing them. And the lovely thing about our practice since 2017, I think, because we are seeing patients on a regular basis over and over again, we can see the changes. We have the conversations, and we learn so much from our patients. It's wonderful. You know, we have all of that insight so that we can help.
Amazing.
There's a question we have here from an anonymous attendee that I really want to get to. So the question reads, I've wanted to start my transition for a long time. I legally changed my name a year ago, but haven't started any hormones, and I'm unsure where to start. I suppose probably more specifically to yourself and your clinic, what would that process look like? What would starting with the gender hormone clinic be?
Yeah. Okay.
Take this one actually, Mary, with regards to at least the admin side of how the things run. So I've been knee deep in it for the past few weeks, helping optimize our admin systems. So with regards to, so what happens is you'll send through your we'll normally get through your referral from one of the psychologists. So normally one of our associates and stuff, we work quite closely with them. So we'll get through your referral form. You'll go on to our like fairly brief wait list, which is just to allow for bloods to be done, us to make sure that you've got a secure slot on in terms of seeing our in terms of seeing one of our nurses. And then from there, it's a matter of we do a initial Zoom conference, which will be just a short one with one of our nurse practitioners, and you'll come in, you'll see us in person, and we'll do a we have these wonderful in-body machines that are incredible, and they'll sort of do they'll do a lot of your body metrics and stuff like that, and then the blood tests will be seen in appointment as well, and from there it'll be a conversation with the patient and sort of getting them started, really. Mary, if you want to fill in any bits I might have missed from the clinical side.
Sometimes we'll get patients just like you've described, Jess, you know, that they don't even know where to start. So you can contact us and we can give you, because we unfortunately cannot see any patients unless they have a diagnosis of gender dysphoria, and that's a whole other, you know, kind of conversation. And they need a diagnosis of gender dysphoria or incongruence from either a psychiatrist or a psychologist who is HCPC registered. This is the way that the kind of the law of the land at the moment. If our patients didn't have that diagnosis by someone who is registered, then unfortunately we would not be able to continue to practice and offer the care we do to our patients. So if you haven't got the diagnosis, then contact us. It's info@thegenderhormoneclinic.com, and you know, we can give you some information, or go to our website. You will see all our associates who can make the diagnosis. Then yes, as Kat says, you know, we'll organize, you contact us. Ideally, we like you to, we have a Zoom consult and we discuss, you know, have you thought about fertility preservation? Number one, organize and get your blood tests done. All right. And, you know, we have an hour for that Zoom video link consult where we go through lots of different things we want you to think about before you come into clinic. You know, is it the right time? Is it the right space? Or you know, are there any complications that need to be dealt with? Do we need to refer you elsewhere? Then when you come into clinic, it's usually about 6 weeks later, you come into clinic, we do a face-to-face, we sit down, have a conversation, we go through your shared care, your consent, you know, we check your blood pressures, Kat says, we do your body metrics, you know, and it just gives us time to get to know the patient. 30% of our patients, you know, they could be somewhere on the autistic spectrum. So it's important that we have that face-to-face and that contact. You see a lot more, you understand a lot more about where the patient's at. And oftentimes it's lovely to have a family member or a friend come in with them. We're very open house. You know, we don't restrict it to you alone. Please bring a family member or a friend to support you, because it's a lot to take in. Yeah. And if all well,
can I just ask one quick question? Do you have to be in the UK? What if you're from abroad?
No, we have patients who come from Ireland, and we have lots of doctors in Ireland who are very happy to prescribe and share care with us. Never had a refusal, I have to say. And we do have patients who come from abroad as well. We would usually write to their medical practitioner in that country and give them guidance so that they can prescribe for them. So it doesn't have to just be in the UK.
Okay, that's good to know. So I'm going to we've got a lot of questions here, and I know there's loads of little things that
I
we
go
can
on.
add,
You
but
have to
we have
tell.
people have
Not at all.
yeah, we've been getting questions all day, but okay, so some quick fire ones if we can, if that's
Yes.
okay. Is it normal to start feeling a bit fatigued after starting hormones?
Yes, you can do. Absolutely. You can. And I'd say just go with it, because your body is changing and it's just getting used to something new. So it can be quite normal.
Okay, quite normal, but it should phase out over time, yes?
Yes, absolutely.
Okay, very good. Now, another quick one. What kind of prices do the private prescriptions of blockers, estrogen and progesterone cost for those whose GP won't prescribe? Have you an idea? And I know it's going to be different if you're international guys, but for the UK.
It's very different. So if you want an injectable blocker on a private prescription, it can cost you over £300. I always say to the patients, a private prescription, some pharmacists will charge you £30 for the paper it's written on top of the medication. So take your prescriptions. If you get a private prescription, it's either Tesco or Asda, because they'll only charge you for the medication on it. Oral, the tablets are cheaper. Spironolactone is cheap. We prescribe a very small quantity of cyproterone acetate. You just kind of have to be careful. Some pharmacies will charge you for a 60-pack, which would do you for about 3 years at the level we prescribe it. So, we do advise on that as well. But again, it very much depends on the pharmacy you take your medication to as to what they're going to charge. But I always advise patients, go in and see what they're going to charge. I know how much generally, testosterone pump, not that my transfemoral patients want to know about that, but I know how much generally that costs. But the other medication, I don't like to be quoting prices, but I do know, okay, so if you're looking at an injectable blocker, it's over £300. That's the most, but otherwise you can, if you bring a private prescription Tesco or Asda, it doesn't cost a lot, in fairness.
Okay, this is good to know. This is good to know, because a lot of people freak out about that. So another question here, not I suppose specifically on hormones, but what is the best way to approach a GP when talking about shared care? There seems to be a massive hurdle, especially at the moment. Yes, there is.
Well, it very much depends on what county you're in. But 90% of the GPs we write to, they're very happy to, help their patients. And I'm very happy to go out with patients who say, look, I worked in general practice for 15 years. General practitioners, they are general practitioners, they're not specialists. So I understand if they don't have the knowledge and they want to do what's in the best interest of their patients, and I want to help them to do that. So if a GP says, I'm really sorry, I don't know anything about this, I can't help, I generally would write to the GP and say, well, look, I am happy to do, a video link teaching for you and all the members of your staff so that I can support you. I mean, only probably about 8 weeks ago, I went to a GP practice in Muswell Hill to do a teaching because they had their first or second transgender patient and they weren't quite sure. And I've had wonderful communication with them since. So it is about education. And I'm very happy to help GPs because I know they're under a lot of pressure at the moment, and not only just time pressures, but financial pressures as well. So it's about education, and it's been about being open to learning.
We also have a letter that we send out to GPs with regards to if they're having a few doubts or just general questions around that we send out to GPs with regards to that as well. So
yeah, I would also just like to slightly add in some, because this one comes up on our WhatsApp group quite a lot, that there are GPs blocking you. There is, and if you're watching this on a repeat on YouTube, look down. The link will be in the description here. But there is an organization that has put together a list of the active GPs in the UK, and this is a live list of where they have got actual help, where they have prescribed. There are also bridging GPs that will help you while you are waiting to get either onto a private system or through the NHS, which might be in 29 years time apparently at the moment. So there are bridging people that will do that. You don't necessarily have to stay within your borough, although I know your GP is going to tell you that, but you don't necessarily need to do that. So if you are in the UK, look down and get that link, and we'll be able to help you. If anybody is watching this and they are from abroad, do get in contact with us and we will do our best to point you in the right direction on that one. Another quick question here, because I think this will be a yes or no, and it is progesterone for a trans woman available on the NHS path?
Yes.
That
Well,
answers that
now,
question.
not necessarily from all the GICs, but, you know, if I write to a GP and ask them to prescribe it, you know, I've probably only had about a handful of GPs who said, actually, this isn't, you know, what I think is, because the NHS GICs don't, then I won't. But if you're on it already and you go to an NHS GIC and you say to them, look, actually, I feel well on this, you know, in fairness, a lot of them now are happy to, you know, recommend it for patients, I think.
Okay, excellent. All right. Now, another quick one. Are you more at risk of blood clotting when your E2 levels climb above 800?
If you're on an oral estrogen, then, you know, yes, you could be, but not necessarily either. It very much depends on your physical well-being. Oral estrogens, I try and avoid them. My favorite is, and I shouldn't actually say this, but I do have a favorite, and patients tend to do very well on it. But I tend to avoid oral estrogens, even for my younger patients. It's not my first go-to, really, because anyone over the age of 40, we wouldn't prescribe an oral estrogen anyhow because of the increased risk, you know, of complications and clotting and that. So I tend to just get them used to transdermals and stick with them because, you know, patients tend to do very well on them.
Okay. Okay. Very good. Okay. Another one, slightly longer question, but not question, but answer possibly. So does estrogen affect fertility for those of us interested in having biological children later on?
Again, I don't have a crystal ball. I wish I did. You know, the evidence has shown that actually the testicles are more resilient when it comes to maintaining fertility over a long period of time, but there are no guarantees. I had a patient who had fertility preservation, trans female patient, who was on estrogen and blockers for 5 years and went back to the US because she wanted to use her storage, her gamete storage, and the specimen was nowhere to be found. They had lost, and she came back and she said, Mary, what am I going to do? I said, the only thing you can do is stop your medication and see what happens. And, you know, it was only like 5-6 months before she was perfectly, you know, fertile again. And that was after 5 years on estrogen and blockers. But there's no guarantee that once you start hormone therapy that it won't affect your fertility. So I always encourage patients to consider it, and it is available on the NHS. You know, the NHS England were challenged, and this was in, I think it was March, 27th of March 2019. They were challenged by an NHS gender clinic because patients, transgender patients, were being refused the opportunity to access fertility preservation on the NHS. And what the NHS said at the time was, well, you know, okay, we can't refuse you, but we leave it up to the different CQCs. Now, the CQCs have been renamed recently and they're called something else. But if you were to legally challenge your CQC, then they would have to offer you the opportunity. But I still do see that patients are refused funding for fertility preservation. And yes, your fertility can be affected. There is no way of telling. But if it's something you think you would like to consider in the future, my advice is, please go and get it done now while you're waiting between maybe your diagnosis and coming, you know, or going to see anyone for your hormone therapy. Please go to your GP. The HFEA, Human Fertilization Embryology Authority, so it's hfea.gov.uk, have a wonderful website. You can go on, put your postcode in, and you can actually, they rate your local fertility clinics. So it's very easy to go into your GP with all of the information they require and say, can you please refer me here? Actually, the NHS do provide funding for this. And, you know, most GPs will do that.
It's
That's
also
amazing.
I had a friend who came off hormones to try and have a biological child with their partner and stuff. It's also worth noting that the mental impact that can have on your life is quite bad, coming off of medical transition, just for that as well, and then also the complications that can happen around actually being able to get someone pregnant, even if you do have elements of your fertility return and stuff like that, can be really difficult. So it's worth getting preservation done beforehand.
Yeah, for sure.
Yeah, I've done some research on this one actually, and there's a lot of people who didn't do that, and they decided, 5-10 years later that okay, hang on, I do want to have a biological child. Now, for the people who came off their medication, you do have to come off your medication. Usually within about 6 months, full fertility came back. But it is not guaranteed. It did not happen for everybody. It did not happen for everybody. But for a lot of people, and I'm talking trans men and trans women here, it can come back. The status quo, or the usual thing, is once you're on hormones, you're sterile for life, and that's it. That is not true.
No, it's
not
not
true.
true.
But there's no guarantee. So please think ahead. Even if you think, I don't want to do this now, 10 years time, you'll be sitting in a very, very different position. So it's easier to do, particularly if the NHS is going to pay for it. Then you don't have to worry about that, whether you use it or not, completely up to you. But it's not what people say. You do not go sterile most of the time. You will get that back. But as Kat said, there's other things to consider if you come off hormones. Okay.
And the NHS will store, your gametes for 10 years. After that, you have to.
Okay. So another quick question here: can GPs refuse to do bloods for trans people?
Well, they do, unfortunately.
But can they?
That's a very good question. They seem to get away with it. They seem to say, if you're, well, okay, if they've been to a NHS gender identity clinic, then GPs don't refuse. If they've been to a private clinic, they say, well, you're being seen privately, so I'm sorry, you have to organise and have these done privately. I had one poor young 18-year-old who was charged £450 by their GP practice, who did their bloods and sent them off privately. So I phoned the practice manager and I informed them I'd be having a word with the GMC and NHS England and whoever else if they didn't refund the young person. And they did. And they didn't ask for payment ever again. So
send Mary out. That's the answer. Send Mary out.
Oh, I would love to get out on the road.
I know we've had these conversations before. It's just brilliant.
Yes.
Another one here, slightly longer, but how should shared care work?
Okay, so shared care is about you come, you see a specialist. There are lots of shared care agreements between NHS providers and private clinics, between NHS and NHS different providers. So basically what happens is we have a 16, 17 page document. It gives all the information about the hormones, the side effects, who to contact, what each individual's responsibility is. And then the prescription that we recommend at the end of it. And then we send it to the GP and we ask them if they're happy to accept, or if they're declining it. If they decline it, we ask them why, because if it's that they haven't got, the knowledge, we offer that. If they're refusing because they say, this is a private clinic, I say to them, well, the NHS constitution states referral to treatment time of 18 weeks to a specialist service, but this patient is going to wait 4 or 5 years. 70% of our patients, 80% of our patients, depression, anxiety, deliberate self-harm, suicidal ideation. If it was your child, would you let them wait 4 or 5 years? Now that hits a very raw nerve, I find. Okay, so I try and have a conversation with GPs when it comes to this, because I want to help them to be able to help the patient at the end of the day. We're talking about patients who have struggled for maybe years and who just want to get on with their life. Yeah. And to hold anyone back from doing that, for me, I think it's criminal. So I'm very passionate about not letting it go, and about writing letters, and about making phone calls, and about trying to educate and support GPs so that they can share care with us in the best interest of the patient.
Okay. Okay. Brilliant. I love that. By the way, there's a lot of questions coming in from somebody who's not saying who they are, which is absolutely fine. But the questions you're asking are non-binary. And we do have a specific webinar that we're going to do on non-binary, where I think your questions will be more appropriate for that one. But don't worry, even though I'm not going to ask that question, I'm still going to get the answers for you. Okay, but we'll tell you. So you'll have to tell me who you are so that I know. So if you could just message me directly, just let me know who you are so that we can get those answers to you, so that you don't have to wait. Now, okay, so another one's here. Okay, I think we've done that one. A very quick one. Would you be interested in doing a trial in injectable estrogen?
I don't think one needs to do a trial. I think the trials have been done. I think it's been proven that it works. Why would you necessarily want to do a trial?
What we have here is, I think we have somebody who's not from the UK and they're being prescribed, from, I think, the USA, I think. Not 100%
Oh
sure
yeah,
about that.
I mean, I see patients who come with testosterone and estrogen from all over the world, and they'll come in and they'll ask us to monitor and different things, as long as it's from a provider that's approved by the FDA or whatever, as long as it's not something that's been made under the counter somewhere. I'm of course I'm happy to support any patients in accessing their medication or giving them advice. Yep.
Okay, excellent. Okay, now I'm going to just go faster because we are like almost half an hour over time here. I'm 48, producing DHT, and my GP won't listen to me, so I'm changing my surgery. I have at home 25 milligrams of Estradiol and 50 milligrams of Estradiol, and I want to start taking as soon as I can, but holding myself back because of any health risks from doing this myself. What would you say?
Oh God.
You
I'd
knew
say,
someone was going to self-medicate.
yeah, well, a lot of my patients come in self-medicating and they've been doing pretty damn well at it. And if they're that desperate, patients would do it. And, but I always think, look at, make an appointment, go and see someone if you can. Go and have a conversation with your GP. 75, estradiol is great. 75 micrograms is better than, is better than nothing, but I'm not going to give advice online. You need to have your bloods done. You need to make sure that before you start anything, that everything is okay, all right? And that it's done safely. Some GPs are really happy, especially if they have a history. You'll see under GPs, if they have a history in OBS and gynae, or if they have a specialist interest in the menopause or women's health, then have a little look at your GPs in your practice and see who has that interest and go and have a conversation with them. The other thing, the General Medical Council, the advice and guidance to GPs is, if you know a patient is purchasing medication online, therefore putting themselves at risk, they recommend, providing bridging prescriptions until they're actually seen under the NHS GIC. So it's about educating patients about, what the advice they need to also give to their GPs on what the General Medical Council. You can go onto the GMC website and Google, transgender, and all of that information will come up. So, arm yourself with the information you require before you go and see your GP. Make it easier for them. Yeah. And have a conversation with them. And most GPs, I think, will be happy to support you. Yeah.
Yeah. We have people who have pulled some stunts on that one, and that self-harming thing, and duty of care, and has come up quite a bit and does tend to work. So that's also good to know, because the more you are monitored until you get used to it, the better.
Yes.
That is like, you're not a doctor. Okay, you're not a nurse. You didn't study this in college. You don't know how this will affect. So you need to talk to people who have, so that you can do this safely. So I understand the desperation, but really, this is something that's going to be in your body for a very long period of time, and there can be lasting effects on this. And so all of this is a marathon, not a sprint. So if you're going to spend hundreds of pounds on prescriptions every month, spend 200 quid on a blood test. Talk to a professional for 150 or whatever quid. It's peanuts in comparison to what you're going to be doing over a lifetime. Just jump in and do it, because you're going to feel an awful lot better about that you're doing the right thing, and that adds to feeling calm about this. Because if you're just randomly shooting stuff up there, who knows what could happen? You could be getting things terribly wrong. And it needs to come from a recognized brand, as Mary said, not that somebody made it under the table. You have no idea what you're getting there. It could be rat poison, for God's sake. So, you know, please don't do that. I understand the desperation of it, but it doesn't actually help. Well, you have to think about this long term, not just immediately. Now, the ladies have already said this takes a very long time to really start taking effect. Most of it is emotional at the first, you know, in the first instance. It takes up to 5 years to see these changes on any sort of change in hormone therapy. So give yourself that time. I know people are desperate for it, but please give yourself the time. Once you're on it for a little while, you'll realize it's not really a big deal. You just get on with life. So I'd like to say that. So somebody's asking here about how long a diagnosis takes. That depends on your GP. It depends on whether you're going public or private. I got it done in a couple of months, but there are people still on the waiting list after 6 or 7 years. So it depends who you're with. So that I just answer that one very, very quickly. So that person, by the way, is the anonymous person hasn't come back to me, so please do, because I won't know who to answer these questions to, because we will cover the non-binary one at a later date. And we are half an hour over. We've been talking for 90 minutes, and I know both myself and Mary are Irish. We could keep going for another 3 hours, but we realize that the rest of you actually have lives. You know, so look, if there are questions here that you either haven't asked or haven't got the answer to, if you just talk to Mary. Mary, can you just give the details again as to where people should go to get in contact with you?
Yeah, it's info@thegenderhormoneclinic.com.
You can
Okay,
also
please be patient with us, but you can also go on, Kat.
You can also go onto our Instagram account. I love answering all of these type of questions, so please do. If you have questions around medication stuff, clinical stuff, admin stuff, you can always pop a message in, even if it's just to do with getting started and changing your name and all of that type of stuff. Like, I'm always happy to provide help where I can.
Yeah, fantastic. And just to say that, yes, we are running this webinars, but please don't forget that myself and Jess run a meetup group, and we have people from all over the world. We answer questions all the time on this type of stuff. We also have a WhatsApp group, and it's a very active WhatsApp group, and people are asking questions all the time. And they're not just from the UK, they're from all over the world. And we welcome people from all over the world. We never, ever, ever want you to feel alone or feel that you can't reach out to somebody. It's there for us. Jess and I just do it because we do it. You know, we're not paid, we just do it. You know, both Mary and Kat have given up their time here this evening to do this with us, and we are forever grateful for that. So please never ever feel alone. There is so much help out there for you, and we are delighted to help you in any way that we possibly can. It's a big one. Mary, Kat, and I will say Jess as well, seeing as that you shared a lot of stuff in there. Thank you so much for partaking with us this evening. Thank you for giving us your experience. Thank you for giving us, you know, all of the years of dealing with this type of thing. It has been absolutely phenomenal. It's not the end, guys, ladies, and whoever else. If you have questions, let us know. We will get them answered for you. Even if you are watching this on YouTube, okay, it is now January 2023. Even if you're watching this in 2025 or 2027, we don't care.
We'll still be here. We'll still be here.
We will still be here. We will still be here, and we will answer those questions. So a lot of the links we talked about, they're in the description box below. Other than that, just get in contact with us and we will do that, okay? Someone's just asking, where do you sign up for the WhatsApp group? You have to sign up to the Trans London Meetup group. So just go on to meetup.com, you'll find us there. Then you either text myself or Jess and we will add you to the group. Okay, so that answers, I guess, that one there. So again, thank you so much, Mary, Kat, Jess. Thank you also to everybody for being on here. I know we kept you way longer than we were anticipating, and I know that we could go for longer. But look, thank you for your time. Thank you for signing up. We will let you know about other things that are coming up. We're doing a lot of stuff ourselves. And you're, God help you, you're all on our email list now. So we'll let you know. So other than that, guys, please, and ladies, enjoy the rest of your day, enjoy the rest of your evening, wherever you are. And look, thank you all so much, and take care, and goodbye, everybody. Bye-bye. Take care.
Bye.
Bye-bye.
Thank you. Thank you.
Bye.
Thanks so much for watching. Please subscribe just so you won't miss out on anything we do. Thanks so much.
Bye.